Olympics tree was just more.
So good afternoon. Thank you guys so much for coming to day 2 of our Inclusive Excellence Week. We are in for a very special treat in that we have Dr. Sarah Raskin here with us today. Dr. Raskin, I'll read a little bit of her formal bio. She is an associate professor with tenure in the L. Douglas Wilder School of Government and Public Affairs, a member of the IQ Oral Health Corps, affiliate faculty here at the School of Dentistry, a former public health practitioner cross-trained in medical anthropology, health services research, and implementation science. She conducts mixed methods community engaged research in oral health equity in the US through an intersectional anti-oppression lens. I happen to serve as a co-chair with her of the Virginia Health Catalyst Future of Public Oral Health Workforce Implementation Team. She also serves as Association for the Anthropology of Policies, Anthropology News column editor, and on its anti-racism working group, super involved with the American Association for Dental, Oral, and Craniofacial Research, as well as IADR, NIH, all kinds of institutes and affiliations. And I will say that she's a personal friend. And in this work of being sort of anti-oppressive, there are few friends to be passionate in the work about. So she is one. So I'm really excited to hear her. Thanks so much for being with us today, Sarah.
Thank you for having me. Thank you everybody for coming. And I will not be offended once we hear that pizza is here, that everyone just runs outside to get some. So in thinking about and Carlos, should I plan to still cut off at 1 just to make, because the room probably, that's cool. Okay, so in thinking about what I want to talk about today, Carlos and I were talking about some of the different kind of topics in inclusive excellence. And I was thinking about some themes that I'm starting to identify, kind of pulling my work together. And so today we're going to be talking a bit about the hidden curriculum, hidden curricula, which I'll define shortly. I want to say I have no disclosures. Some of the work I'm presenting here has been supported by CareQuest in the past, but I have no actual disclosures for today. And you've seen the learning objectives. They're how you're getting CE credits. So I'm going to quickly kind of run through them. But I also just want to acknowledge, so typically I open my talks with a little bit of a statement of like who I am, what I do, and why, a little bit of a positionality statement. And this is partly just about like my personality. It's partly about the diversity work, the DEI work that Carlos and I do. It's partly about being a qualitative researcher, in which kind of stating our position is actually key to the science that we do. We don't pretend to be at objective distances, because many of these topics are actually very personal, and the lenses we see them through are very personal. But I'm going to kind of pivot a little bit, because the last 10 days have been very heavy for many people. I don't know how heavy they have been for you all in here. They have been very heavy for me. My father and stepmother live just north of Tel Aviv, and a very dear friend's mother, Palestinian American friend, lives in the West Bank. So I just want to acknowledge that there are some heavy feelings going on right now. I am delighted to be around people. And if you see yourself on this wheel in any of the spaces that are maybe a little bit heavier, I won't take it personally if you need to like step out and take a breather. So I want to kind of introduce this concept of hidden curricula through a parable using emojis. So when I completed, or when I was training for my public health program, we would often joke that when we would have symposia that brought together students from the School of Law and students from the School of Public Health, and this is at Emory, right? So there was also the layer of like southernness to it. For example, formality, a very elite institution, that you could tell who was who at these symposia. They would often have to do with things like access to HIV medications and the role that like big pharma plays, or their legal mechanisms or their ethical mechanisms to try to increase access to HIV medications around the world. And we would joke that we could tell who was who in the room, because the law students were always in suits. And the public health students, majority women, were always in sweater sets, a twin set, like right here with a little cardigan. And, and we could kind of joke that you could like figure out who was who in the room. And so when I come over here, to the School of Dentistry, I go through this question in my mind, like, what is the culture of the School of Dentistry? What do you all expect me to look like? As it turns out, I also go through this same question every single day in my own unit, because I am in the unit of a school of policy, and that tends to be a much more formal setting than anthropology, which I have denoted here, with wearing like Chelsea boots and a knobby sweater. Although the truth is that mostly when you go to our meetings, you'll see a ton of scarves. There was even like a whole Twitter thread about the scarves at anthropology meetings. And so I introduced this to say that we are all constantly existing through hidden curricula throughout our daily lives. So I'm giving you some language to be able to talk about it if you're not familiar with this term, but you probably kind of already intuitively know what I'm talking about. I also want to say that for someone in my position, newly tenured, as Carlos very generously just shared, like there's just more than knowing the community that we're fitting in and out of. There are questions constantly of power, status, relationship, risk, right? So for example, for someone like me, who is feeling pretty confident in my status at this point in my life, this is kind of a matter of degrees and preference. I probably kind of like hit the middle on it, something like today. But when we think about people for whom the stakes are much higher, think about someone being authentic in their gender performance. Think right now about women who wear hijab or, Hasidic Jews who very clearly are denoting their status in the world. It is not simply a matter of how to look cute. I won't say whether to look cute, how to look cute. It's also really a matter of actual stakes. And we actually navigate these bits of safety every single day, whether we know it or not. So Gonzalez and colleagues wrote an article about implicit bias instruction, which I know is something very near and dear to Carlos, to Dr. Smith's heart. Sorry, I'm calling you as a friend, but I know students in the room were calling you Dr. Smith, talking about the roles of hidden curricula in terms of implicit bias instruction. And they define hidden curricula as the culture of an institution, interpersonal encounters, and what, in their case, students or people learn outside of what we're taught in the formal curriculum. So some people talk about an iceberg model of culture, where what we think of as culture is kind of that top surface stuff, the practices that we navigate every single day, our behavior, our language. And I don't just mean language like English versus Spanish versus, Dutch, but I also mean like the words within that. But so much of our culture lives beneath the surface in our shared thoughts, beliefs, feelings, assumptions. I want to be really clear that we're all navigating multiple bits of culture probably every single day. Culture is both totalizing systems and also is multiple systems. So we're navigating this every single day. And so I want to say up front that very much what I'm talking about today is about unconscious, implicit experiences. It is not about individual blame, because I'm actually going to share in a little bit about how some of my own biases have come out in some of the mistakes that I've made in my life and how some of those biases are reflective of the hidden curricula that I have been socialized into. But I just want you to keep this vision in mind that like 80% of what we think of as culture is hidden beneath the surface, if we're going to get into kind of a proportionality. So much of what we think about is hidden beneath the surface. And so I'm going to invite you to take a moment to reflect on what you have learned outside of your formal curricula about the cultures of your dental education. Who are your instructors? Who are your classmates? Who are your patients? What do you learn from your textbooks that isn't simply the words or the images? What do you learn from practica? What do you learn about entry into practice? Same question about the culture of your dental practice. I don't know if anyone in here is a provider, but if you were, or if you could imagine yourself as a future provider, who would your team members be and what would be the arrangements or the relations among them? Who would be your patients? What do your workflows like? What does being in sync look like? What does conflict resolution look like? And similarly, thinking about the cultures of your professional community. Who are your peers in your professional community? What are your priorities, your agenda? What are your ethics? What events do you participate in? So I'm going to invite you to just reflect very, very briefly on those things. I'm not going to ask anyone to share. And meanwhile, I'm going to make sure that I change the screens a little bit so that I can keep an eye on the time. Great, so that we don't go over. So I said a couple moments ago that hidden curricula have stakes. And so now that we've done the example of me showing you how I navigate, how I dress, whether I'm in public health or a dental school or school of policy, or whether I'm at my daughter's Girl Scout or my daughter's Girl Scout troop, or whether I am participating on an NIDCR panel. So I'm going to give you another example of the hidden curricula of dental research that was recently revealed to me. I had the opportunity to serve for the first time ever on a review panel for National Institute of Dental and Craniofacial Research. It was really fulfilling. I had applied as an early career researcher who wanted to learn about the process of grant review. And so I sat on a 2-day panel and I did a lot of listening. I had to review 4 applications and then participate in the rest of, and these are like intense, it's like 15-minute turnarounds, like just gobs and gobs of different applications to learn. And a very interesting thing happened on the Thursday night of a 2-day panel that I was on. On Thursday night, about 5:15 p.m., everyone in the virtual room's phones started buzzing. And it was because the Supreme Court had overturned affirmative action. So here we are, dental and craniofacial researchers who are evaluating the applications, including of junior scholars. And we just found out that affirmative action had been overturned by the Supreme Court. No one commented on it that night. We all went about our evenings, came back into the Zoom room the next day, that like 9-hour Zoom room, so exhausting. And we made it through the first couple of applicants. And I'm gonna, obviously I can't disclose like any detail that has to be confidential, but I'm gonna kind of speak broadly about what happened. For the first time, I really heard how common it was for reviewers to say things like, oh, well, this applicant is being trained under so-and-so at the such and such prestigious institution. And that person has mentored 4,000, not really, 30, periodontal researchers or, whatever. Started kind of getting these like glimmers of the prestige apparatus that was coming through in these conversations completely acritically. And listen, it is also very important that we give opportunities to young to junior faculty members or, emerging junior faculty members to be like mentored under accomplished scholars, right? Like that is how we train them in both grantsmanship and science. At the same time, an applicant came up whose application was novel, important question, appropriate methods. But I heard this applicant be talked about as someone who was not proposing to be trained in a prestigious setting. In fact, they were proposing to be trained under a relatively mid-career person who had less experience as a mentor. And I heard some other things about this student. This student, a dual degree DDS Ph.D., lived on the US border. According to their CV, had started in community college, had then served abroad in the military, had come back and gone to dental school, had decided while in dental school to go into research. So I was hearing that this student maybe had entered into the trajectory of career cultivation that was appropriate to their life and was what they knew how to do without knowing that you can just email, or without having the confidence that you could just email someone at the Forsyth Institute at Harvard University. Maybe a person just doesn't know that they can do that, or maybe they did do that, but they were dismissed because they didn't have the credentials that we identify as associated with prestige and therefore with success. And so, for better or for worse, I stuck my hand up in the room in the open discussion, and I asked this very question. I said, what is our stance? And I used the word hidden curricula. That was actually the day that I decided to talk about that in here. What is our stance on how students who maybe don't even know how to navigate prestigious lineages of research, if they are asking important research questions, demonstrating the technical skill, have the letters of support, and maybe they just didn't know that what they needed to do was, I don't know, figure out how to pick up and move to Boston? How are we to evaluate these people, especially in a moment when these applicants are under threat from the Supreme Court of actually having their opportunities foreclosed upon? And I was actually scared to ask that question, but I was glad that I did. And it actually raised a very good discussion in the room in which quite a few people kind of explained that very reasoning had helped them bump their score a little bit to make sure that this person had every advantage to try to be funded to complete their study. And as it turns out, this observation is not unique to me. There was actually, just earlier this year, a study that came out documenting the profound inequalities among recipients of multiple NIH research grants. So people who are what they call super grantees, super principal investigators, that is, who have 3 or more major NIH grants. Even after, it says, I'm going to read this directly, women and Black PIs were significantly underrepresented among super principal investigators, this is 3 or more, even after adjusting for career stage and degree. Women and Black PIs were 34% and 40% less likely, respectively, than their male and white colleagues, respectively, to be an SPI. Black women PIs were the least likely to be represented among SPIs and were 71% less likely to attain SPI status than white men PIs. There are lots of different hypotheses about why. What research questions are diversity researchers, sorry, I don't mean researchers of diverse background, I mean people who are studying diversity, equity, and inclusion. Does NIH value the research questions and specific aims that they're asking, right? One hypothesis is that they are less often funded because our major funding institution doesn't value those questions or doesn't value them as much as compared with other questions, The example that I just gave of the dual degree student, the DDS Ph.D. student, another example, right? Like I said, maybe doesn't understand, it hasn't been introduced to the kind of prized trajectory in terms of putting together a mentorship team from different, prestigious institutions. We can't know all the reasons yet. There's a bunch of research in this field, but I just kind of call this out to talk about the stakes, because these stakes have to do with career making. They also have to do with mentorship of next generation. And also, as we'll talk about in just a minute, they have to do with patient services. I should also say, we can hold questions for the end. We can also we're a small group. So if you all have questions, we can just kind of raise some points and questions now. So let me pause before I move on with a couple more examples and see if there's anything else I need to unpack to this point. Okay, so now I'm going to get into a couple of examples of hidden curricula from dental professionalism. So the first one that I want to bring up is probably a report that almost everyone in here has probably read. This is from the American Dental Association's Health Policy Institute, where they produced some phenomenal research on the field. And this is the racial and ethnic mix of the dentist workforce, excuse me, in the US. And I should say that as asymmetrical or unbalanced as it is in terms of dentists, it's actually even more imbalanced in terms of dental hygienists. So I have to say that like other dental professionals, there is work on this also going on, and it's even more imbalanced. So as we can see, the percentage of the US population of white people has actually reduced from 67% in 2005 to 60% in 2020. That might be partially a measurement issue as the US Census changes its measurement categories. At the same time, we can also see that similarly, the distribution of white dentists in the United States, the proportion of white dentists in the United States as a total percentage of the overall proportion of dentists has also shrunk over time from 79% to 70%. So you can see kind of the like narrowing, the V-shaped narrowing over time of the white population and the white dentist population. We can similarly see that there has been growth in some communities of dentists. So for example, the proportion of Hispanic dentists has grown over time in the last 15 years from being 4.2%, that's in the green, I'm sorry, I didn't bring a pointer, from 4.2% in 2005 to 5.9% in 2020. So a gain of about 1.5% over 15 years, but the population of people identifying as Hispanic or Latinx in the United States has outpaced that substantially. In the last 15 years has grown from 14.4% to 18.4%. And meanwhile, the population of US adults who identify as Black or of African descent has really stayed the same. That's the orange bar on the right in the over 12%, 12.2, 12.3, 12.4. The population of Black dentists has also stayed flat like that at 3.7 to 3.8. So we have an underrepresentation of Black dentists by approximately 2/3 relative to the overall US population. Now, this is a fact that probably many folks in here are familiar with, but I'm actually here to talk about some of the more subtle components of what we're looking at when thinking about things like why have we had such a flattening of Black dentists in the United States and a real lack of growth in that way. And I'm here to argue that hidden curricula partially explain this imbalance. So Dr. Smith and my colleague and friend, Eleanor Fleming, who many of you might have met, she's the inaugural Associate Dean of DEI at University of Maryland School of Dentistry and an astute dental epidemiologist and just a really great person. She and I conducted a study to understand the experiences of Black, Latinx, and American Indian students interested in dental careers. We conducted focus groups with students and interviews with administrators to try to understand some of the kind of unseen factors that might determine the entrance, completion, and then placement of historically underrepresented minority dental students throughout the course of their education. And we found a couple of really important things in the words of these students themselves. So first of all, there were specific challenges that all of these students encountered in terms of entering dental professional training programs. We heard specifically that students were discouraged from considering dental school as an option when they were pre-dental, when they were like undergrad in biology, because their advisors did not think it would be a good fit, gave no other clarification of what does that mean, right? Like, what does it mean for a pre-health advisor to determine whether something's a good fit for you or for me or for your kid or for my kid? But they experienced that in specifically racialized ways, that was a determination based on their own racially minoritized identity, because often those advisors would redirect them into less prestigious careers. And here we're talking specifically about dentistry, not about dental hygiene or dental assistant. Other challenges that they encountered included things like not having a personal relationship with a dentist to come do an observation, a period of time observing in the dental practice. And therefore, it was prohibitive for them to be able to demonstrate on their CV that they had done an apprenticeship. They weren't able to write an essay about how they had done that. And that is for a couple of different reasons. Some of them did not have a personal relationship with the dentist who they felt they could ask that of. Some of them felt that they did have that relationship, but they couldn't forego the income because maybe as undergrads, they also worked during the summer or in the evening. And oftentimes, their dentist, when they were a child or an adolescent, had been a white person, and they felt a lack of ability to ask for something in that relationship as a direct result. They also talked about how fit to them was multifactorial, and this means fit in terms of the community that they would enter into. So a couple of students who participated in our focus group discussions talked about the importance of going to a university that kind of made sense to their life. So whether this was some of the Black students involved in our research who went to HBCUs, right? So maybe they went to HBCUs, historically Black colleges and universities. So maybe they went to like Morehouse undergrad, Howard for dental. And then they were thinking, well, they'd like to go for postgraduate education. They'd like to do fellowships or advanced training or specialized training, but they had fear that those items on their CV would be less prestigious and would not be welcome so far as applying to fellowships or applying to academic careers. We also had students, in particular, actually these were professionals, American Indian professionals, who spoke to us about the importance of fit in terms of proximity to family. That the need to go to and I don't want to overgeneralize, right? Like this was a couple of people who told us this, but for these administrators who lived in the US Southwest, talking about the importance of fit in terms of proximity to family and a family life meant that they were limited, and there was like kind of a one-shot application only to like AT Still or, somewhere that they could still go home on weekends and spend time. And so that really eclipsed some of their opportunities to apply to other schools because geographic desirability was so important to them. And then finally, students who did go to minority serving institutions, so going back to like HBCUs, for example, like Howard, talked about the importance of the investment in these students that was not just financial. It was scholarship money for sure, but it was also like mentorship and understanding and a commitment of faculty who looks like them. And that is what drew them in there. And so I share this to say that I am here to posit that our findings from here help explain some of these findings. And Eleanor and I are, and these are two students, by the way, who we worked with. We are not alone. There are, and I will make these slides available, there is more evidence about this particular dynamic from both, our own Dr. Smith, who has written about academic dentistry and racial battle fatigue. So why do we see so few academic dentists or administrators from historically underrepresented minority identities? Part of it might be exhaustion, that the fight to get into those roles is so exhausting. There are real questions about the personal sacrifices that people have to make to go into them. I also want to say that for all the concern that I shared on this slide and that you've seen, this is for dentists overall, doesn't differentiate by specialty. It is far worse for specialties. I actually have saved on my computer, but I didn't share. Can anyone guess the year that the first Black female orthodontist was licensed in Alabama? It was 2015, and I have the newspaper article. It was less than 10 years ago. We should be outraged. Now, I also want to argue, and I'm going to start speeding up because I'm realizing that even though I started late, I've been like, pontificating more than or as much as usual. I also want to share that it's, I will stand up here every time and say, people should have the opportunity to pursue the careers that they want for their own fulfillment, right? Like for their own fulfillment. Also, there is emerging evidence in terms of the impact on patient care. So there's a concept on the medical side called concordance. It has been demonstrated that Black women whose prenatal care is delivered by a Black OBGYN practitioner, their babies have better outcomes. These outcomes have actually not as much been demonstrated for the women themselves, but that their babies have better outcomes. All sorts of theories of why. Theories about minimizing stress, theories about the investment of the provider in these babies' outcomes. There's been similar research in terms of the handling of pain, pain medicine among underrepresented minority patients, and that when they are matched to underrepresented minority providers, they tend to have better pain management because their pain is believed and affirmed. If you've never read the study out of UVA, also from about 2015, that documented that providers underestimate the need of pain management among Black patients. It is a galling study and it is worth a read. So I've been working with CareQuest to conduct a national survey about the experience of patients in terms of their experience of discrimination within clinics, as well as what we are calling indignities, microaggressions. There's been a fair bit of research on the experience, the effects on oral health outcomes of patients outside, their discrimination experiences outside of clinics, but we're interested in within clinics. And we have found, and I'm going to refer to my notes to make sure I get this really, really right. That is a big table to stare at. But we have found that for patients who report an experience of discrimination, of explicit discrimination in a dental care setting, they are somewhere between 1.6 and a little more than 1.5 times likely to report their oral health status as fair or poor, to report not having had a dental visit in the 2 prior years, and to not be planning a future preventive visit within the next year. But when we ask about dignity, when we ask about microaggressions and the more subtle experiences of not feeling believed, respected, not trusting an oral health provider to work in their best interests, so forth, we find a more than 2 times effect. Not only do patients report a fair or poor oral health status, have they not had a prior 2-year oral health visit for any purpose, but they are in the 3 times plus less likely category of planning a future preventive visit. And while we did not ask patients in this national survey, which is a representative sample, we didn't ask them to report on the race or ethnicity of their provider themselves. We think that that is a direction that we should be looking at. So let me move on and talk about 2 other examples of hidden scripts in dental practice that I think are a little bit kind of maybe harder for us to get our hands around, because I think that the literature on racial and ethnic inequities in dental practices, it's kind of proliferating. There's more and more of it all the time. Here, I'd like to talk briefly about top of license practice. So I don't know who in this room is a dentist or a dental student, although I could take some guesses from Scrubs, right? And of course, I know, that Dean Cooper and Professor Smith are, both licensed dentists, but I don't know beyond that. I also don't know who in here is a dental hygienist, who in here is, an administrative staff member. But I want to share, and this is a bit old, this is from 2016. These are graphs of top of license practice among dental hygienists by state. And this has certainly changed in the last 7 years. So here in Virginia, for example, we have broader top of license practice from dental hygienists working in community settings as permissible. It's not yet highly operationalizable. That's something that we're working on in the workforce group, but certainly we are I would say, in the center of top of license practice as compared with many other states. Now, top of license practice has been found to increase dental utilization, including in particular pro fees, because they can be completed under top of license practice semi-autonomously in dental safety net settings. Increasing dental hygiene professional practice has also been associated with reduced cost to patients and payers, right? So these are like public health success stories, right? Like more preventive services, lower costs, also has been demonstrated to reduce preventable emergency department visits, in particular among older adults. At the same time, NASA, who is at the ADA's Health Policy Institute, and I should say that this second paper, the NASA paper, has actually not been peer reviewed. It's published in a cool forum, but it's not been peer reviewed. But he has found, his colleagues may have found, that when there is an expansion of dental hygiene professional practice, top of license practice, and this is across the states, not at individual practices, there is a higher staffing levels. Makes sense, right? Like dentists can then hire more hygienists to deliver more preventive services, provided that they are permitted within the law of their state in terms of the distribution numbers of how many hygienists they can supervise at a time. There are fewer dentist visits per week, probably offset by those hygiene visits. Lower patient wait times probably sounds like a success story on the patient side. But there's also lower dentist net income, that actually introducing top of license practice has a depressing effect on the net income, and that oftentimes they think that dentists are making up for that revenue by introducing publicly insured patients into the practice. Now, depending on who you are and where you sit, that might sound like a great thing if you're me, right? That means that more underinsured or Medicaid insured patients have capacity to be seen in states where top of license practice is a norm. However, in a revenue model, as we are living in right now, right, that actually sounds like a tremendous risk for introducing top of license practice, because not only might that depress the net income of the practice, but it might kind of put some pressure on the practice to accept Medicaid patients. And I would argue that this is a hidden curriculum in and of itself. That the concern of feeling the pressure to absorb publicly insured patients is very antithetical to how we approach dentistry in the US, and in particular in the last 20 years. And so I'm arguing that hidden curricula about revenue actually might explain the limited adoption of top of license practice. There are all sorts of other hidden curricula that might explain it, having to do with hierarchy, gender hierarchy, professional astuteness hierarchy. But I think that there's really something about this concern about the pressure to absorb publicly insured patients. And so if you thought that was spicy, let me get to my final point. So the way that I came to do this work is I was a medical anthropology PhD student trying to figure out my dissertation plan. On the good advice of my advisor, I went to where I wanted to work, which was my home region. I grew up in Bluefield, West Virginia. I went to Bluefield, West Virginia and drove around the region 15 years ago to try to figure out what would be a good topic to work on. And oral health came up, and it happened to be a weekend of a mom, right? Pure dumb luck. I like literally stumbled into the Mom Project. My family is a family in which volunteerism is an important value. I started volunteering that weekend when I was there 15 years ago, and I have volunteered almost every year since then. I literally was in charge of the general volunteers this year. That's where you might have seen me, as I was on the top level. Volunteering has arisen as a social responsibility in dentistry, and that is generally beautiful. However, there are some real hidden consequences of a charity-focused norm that I'd like to share with you. So we can think about kind of where the charity-focused norm originates in community-based dental education, which in the 90s replaced, or beginning in the 90s, really in the 2000s, replaced dental public health and community dentistry specialties. Those were really kind of phased out beginning in the 90s. And community-based dental education became an elective coursework accreditation requirement in 2015. And even as early, I wish I could remember the year of this Meridian article, but it's old. I think it's a good 15 years old as well. So community-based dental education delivers substantial volumes of care to patients with unmet needs, and resolving suffering is fundamental, right? Like we all want to resolve suffering. However, it has also created a bit of a charity-focused norm among practitioners today, and evidence has actually documented that clinicians who participated in community-based dental education, ultimately, when they go into practice, their service contributions in terms of dollar value are actually only $2,000 higher annualized to people who did not participate in community-based dental education. So the good news is that the dentists were gonna give volunteer service regardless of CBD, according to this one study, which is a national study, and I'll be glad to give the citation. At the same time, students who have participated in CBDE and have been studied, actually, there has been findings that their empathy and their sense of social obligation to select patient groups, in particular those who are low income, Medicaid insured, rural residing, and non-English speaking, actually has measurably declined following CBDE experiences, even among community-based dental education practitioners whose commitment exceeded 4 weeks. And unfortunately, this has been found repeatedly in universities like ours. It's been different in kind of service-focused universities like East Carolina. I'm just realizing that I have exactly 1 minute. So I want to just say that I really appreciate you all hanging with me to talk through some examples of hidden curricula. I want to also say that some strategies for change I think we all ought to be thinking of include those proactive efforts where we speak out, where we identify a piece of a hidden curriculum that is harmful to our peers, to our patients, to our mentees, and that we really need to be vigorous in thinking through kind of changing the future of dentistry as a group. And I just want to thank you by leaving you with my beautiful perm and diastema, and just say that I'm available for questions after this or follow up by email. So thank you for having me.
Thank you, Dr. Raskin, for sharing a ton with us, a lot to unpack. We may have to have like a fireside chat after to kind of unpack it all together. But thank you so much for joining us today. And she'll be around if you guys have questions. I think there might be a class in here after.
Can we move to the Isaac room?
So that's fine. Yeah.
Yeah, that would be great. Don't continue next door.
Yeah, let's go down there, Russell.
Yeah.